Because we've all agreed that since her troubles were transient, that intubation was an appropriate form of therapy, in spite of the fact that overall, in the event of a death, she's not to be resuscitated.
Right. But I guess my concern is that being that she's been intubated 5 times in 6 months.
Yeah. But each time with a reversible phenomenon.
Right.
Look how much better she is
right.
now. So,
no, I agree.
So I think that would still be appropriate part of regular care as opposed to...
So with any
in other words,
type
if she
of
went
respiratory
into,
defect.
if we extubate her and then she has a VF arrest and dies, she's to go. But if, as part of hypoxia, we decide to reintubate her, we'll do it again. I wouldn't hesitate to do that. She just has marginal lungs and decompensates with either failure or pneumonia, but those are both reversible.
True, but in the broad spectrum of the picture, she has COPD to begin with. She's now immobile. She has very poor airway clearance to begin with. Aren't we talking about a chronic situation?
Yes, we are, because she's going to go to a chronic hospital from here, but still she's entitled to life if she can get it.
For sure. I guess what I'm actually bringing up is there any concern about perhaps tracheing this lady?
Oh, yes, depending on how reversible
Right, I
it
guess
is
that's
and
what
how-
I'm asking.
Yes,
I mean, is
yes,
that
there
going to be
has-
the only way to protect
that-
her airway?
Well, we're not sure that that'll protect it, because even the trach doesn't prevent you from
Absolutely.
aspiration.
Surely. But in knowing how he's dealing with things, if that has to end
We,
up
in fact,
coming-
have sort of started to explore that with him.
You have?
What
Oh,
his
okay.
reaction would be, I don't know yet, because we haven't come down to the moment where we said, well,
We use the
now
words.
you must make a choice.
Yes, yes.
Yeah. Okay.
So at this point, then, for any respiratory compromise, you would
We
want her
go the usual
reintubated.
way, yeah.
Okay. All right. Thank you very much, Dr. Curran. You did do yesterday.
Let's do this then. Let's put her on 30%. Let's bring her down to 4. Let's get a gas on 4, see how she's doing, and then we can decrease her for a while and see how she does.
The problem with her is that she really feels a difference between 6 and 4, and she'll tell you she's short of breath. But her rate actually is no faster than what it is when she's extubated. Easier said than done. I mean, that's how she breathes.
What are the plans in terms of reinfection?
Well, I'm glad you brought that up, because I just had a talk with Dr. Curlin about that. And his feeling is that if he just left, if again she has any type of respiratory compromise unassociated with a VTAC or VFib arrest, that she is to be reintubated. So I said, but she's been intubated 5 times in 6 months. Are we talking about something more chronic in terms of protecting her airway? Because she's always going to have a poor airway clearance. She does have COPD. She does have failure. And he said, well, he has thought about the discussion of a trach with Dr. Factor, but hasn't yet brought it up. But as it stands right now, he would want her reintubated for any respiratory compromise. So
Okay.
that's where we're at.
Okay.
All right.
Well, but it sounds like we have a plan, though. I mean, what George is saying is that, we get her off the ventilator, she fails again, then we do a trach. I
He
mean,
said reintubated. Yeah, we have to think about a trach.
Well, but I
He's
mean,
still putting the
that's-
trach
yeah,
in
but
a
that's
very
the-
futuristic
But that would be the next step.
Right. But I'd rather hit him with it before she actually gets extubated this time, being that she may need to be reintubated during the night when no one's around other than those of us that care
Well, but you
for
wouldn't do
her.
a trach in the middle of the night.
No, but that's what I'm saying. She would get
Yeah.
reintubated,
Right,
and then
but
we'd be
it-
back to having this discussion again without any little
Plan.
longer term
Right, that's
plan.
right.
That's all I'm trying to say. Is that there's a very good chance of it happening again. She's doing fine, and I think we
Well,
will
it's
get
gonna
extubated
happen
by
again.
the end of the week.
It's going to happen again, whether it'll happen a month from now or 2 weeks from now or...
I think it's kind of cruel to keep putting this little old lady through being reintubated all the time, too. I mean, that's not a
Thank you, Mary.
simple procedure.
Right. Well, I don't know, maybe...
I don't know what his
can't make up
reasoning
his
is.
mind. Maybe he can't make up his mind whether he wants to, whether he wants to just call it a day and not reintubate her. I don't know. I'll talk to him some more about it.
Okay.
So I just think it's really
It's difficult. I get so mad at him, and then he shows up with these cookies every day. Breaks your heart. Anyway.
Dr. Factor, you can go in and see your wife if you want to.
All I think to do would be to do a trach if you want to keep pressing on here. Just because
It's a terribly difficult case. Her husband, as you know, has agreed that it would make no sense to do the resuscitative procedure. On the other hand, to keep preventing exactly this kind of thing which is going on while she's alive, I think that might be worth considering. But she was a strong member of the family. She'll have opinion herself about whether she wants to do this, and she is...
I think we should talk to her about it because I think that, you know, the pattern over the last couple of months is pretty clear that she's, you know, I mean, she's aspirated 2 or 3 times. I mean, with the stroke, I mean, she's just not... I mean, I suppose, you know, even with the gastrostomy, you know, which I suppose would be the other thing
But she already has a feeling. Doesn't she have a feeling gastrostomy already? That just doesn't protect you.
Well, that's the thing. I mean, she can't handle her secretions. She has no bulbar muscle. So, I mean, it's gonna, you know, maybe 2 weeks, but you know, it's gonna be. I think we should probably talk to her about it now. She's got the tube out.
We'll rediscuss it with him first, but then I think that the ultimate decision has to be made by her.
Right.
All right.
All right, well, you know, I think there are a couple of issues. One is that, you know, she failed admittedly, the long-term problem is going to recur. You know, eventually she's going to reaspirate, she's going to get another pneumonia. And if she has a trach, then you can treat this. On the other hand, she may not want a trach. So, I mean, I think that I'll talk to her about a trach right now. I'd like to get her opinion sort of when George isn't here and sort of see what she, you know, how she feels about it. When her husband isn't here because he's pretty fragile. So I'd like to talk to her myself about that.
Nobody ever tells her what's going on. Certainly her husband doesn't. We don't. And George doesn't. And she expressed that frustration yesterday to Sue, you know, after George left.
Yeah, well, George hasn't never done it either.
She didn't say anything. She just rolled her eyes after he had been, you know, very chipper and how good she was doing and all this stuff. And she
Well, there's
clearly
no
was
time like right now,
disgusted
so
and
why don't I talk to
frustrated.
her now and then I'll catch up with you guys.
Okay.
Well, in terms of the plan for the day, then, we're going to try to wean to extubate again today? Or, I mean,
Just buffer gases there.
Yeah.
She likes IMV of 6 seems to be a good
Yeah.
place for her. So
Well, let me
I'd-
talk to her
I mean,
first and
let's
see
give
how
her
she
a break,
feels.
you know.
Well, let me talk to her first and see how she feels. I mean, my own personal feeling would be that I would try to get her gases buffed and try again tomorrow, but I would do it a different way. I would T-piece wean her and give her some diuretic and see if you could
in the past, she's
get her
always
off.
T-piece weaned. She's never been cold turkeyed.
Well, I think we pulled things in a little. We were a
Tried
bit
it different.
abrupt yesterday, and that she went into pulmonary edema in part because of that. So, I mean, my inclination would be to sort of get her buffed up today, give her some diuretic early tomorrow morning. You know, when she's on sort of 4 breaths, and then put her on.
Right, we her on an IMV of 4, and
Right.
that usually
Yeah.
pulls her longer than an hour once you T-piece her and extubate her.
Exactly. And my feeling would be is, that, you know, depending on what she says today, you know, either, you know, she comes off the ventilator tomorrow and she does okay and we don't re-intubate her, or she doesn't come off the ventilator tomorrow and she ends up going for a trach, if that's what she wants. I mean, is anybody else? I mean, I think the thing that makes this case tougher than some other ones is that, George is not so free-flowing with his feelings, and he really likes to keep control of the case himself, so that it's much more difficult to sort of deal with him and sort of say, well, and he's not inclined to sort of really open up to her and sort of tell her, he's more the kind of doctor who's going to just sort of do what he thinks needs to be done. He's going to go in and say, you need a trach, rather than, these are your choices.
Well, I think you just have to take into account before you speak to her that most therapies she refuses, from chest PT to albuterol. I mean, everything is no. So you have to think about that when you're asking her for her honest opinion of how she feels about a trach. She doesn't want to do what we do to her on a day-to-day basis if you just went by
well,
that.
Then, I mean, if that's
That's a
true.
really significant
I mean,
fact.
if that's true,
nobody
then,
has ever
you have
asked
to wonder
her
whether
that.
we're,
This isn't fair,
who's, who are we doing this for?
Exactly.
George or her?
That's what I'm saying. Is that clearly, I mean,
Any
with
thoughts,
all her
Radine?
admissions, she said no to most everything. But we don't usually give her the choice.
I think
Well-
clearly she should be able to make the decision.
All right,
And that's the hospital policy, right?
right.
She's certainly with it, and I mean, she is almost always with it enough to make those decisions.
But if the decision...
She usually is, this is not her best time of the day either, though. Around 11 or 12 o'clock. It's really, quite frankly,
Well,
it
but
takes her
see-
a long time to wake her up.
I'm trying to be a little proactive here. I'd like to get in there before Curlin
Absolutely.
comes
I
by.
tried.
He's a grand rounds. He's not going to be up here until 10:30. So if I can talk to her now, and then say to her, "Listen, George, she doesn't want a trach." I mean, then I can take. I'm going to have to. I'm going to have to take him on. Because he's going to. And then he'll give me a lot of crap about how how dare I talk to his patient. And all the rest of this.
Blame it on the house stick.
What?
Blame it on the
No.
house stick.
Big boy, I can take care of myself.
You're bigger than he is. She doesn't want the trach. She has to know that the option is not to be re-intubated every week.
Listen,
And she's going to die.
I can make it clear to her what the options are. I think I know what the
That's good
options are. But I think the thing that jacks up everybody's anxiety in a case like this is that, it's got an attending physician who's,
Who may not agree with this,
Well,
with her wishes.
yeah, I mean, the whole, everything here is sort of built on Quaker concept of consensus, It's what the patient wants, the house staff wants, the nurses want, the doctors want, and what the family wants. And every time you have difficulty, it's because one of those elements is out of sync. And that's what we got here. Not from the family, not from the patient, I don't think. Not from the nurses, and not from the staff in the unit, but from the doctor. So let me talk to her.
Still, if she clearly is, agreeing, he
Yeah.
won't.
Yeah, and as a matter of fact, when you pushed
When I-
the DNR, when she looked like she was going down to...
I hardly pushed. All I did was ask.
Right.
And her husband said, that's ridiculous. I wouldn't have wanted you to do that in any case. So then when I presented that to Curland, he said, fine.
I think that,
Well-
maybe George will be relieved that we do it for him.
Yeah.
Well, the one other thing you have to know in terms of Dr. Factor is, yes, he can say, oh, no, I wouldn't want you to shock her and pump on her chest. And he was surprised that it took so long for us to even bring it up. That's what he said to me. However, when she is short of breath, his anxiety goes like this. He drags me in there, whether it's on the vent or it's extubated, and I don't know.
All right, but a morphine drip can take
Yeah.
it.
Right. I mean,
You can keep it comfortable.
Okay.
Thank you. Medical intensive care, can I help you?
I think all concentration is taking the next breath.
Yeah.
I don't think it was anger or
She
something.
understood everything in there.
Oh, absolutely.
Definitely. And I
Absolutely.
think it's great.
And Scott was good with her. I mean, he went over everything he talked about with her and wanted me to see what she was saying. And it sounds to me, and it looks to me like she was in complete understanding of the options. And I did ask her, I said, all the other times, this is the 6th time that you've been put on the breathing machine. Did you want us to do it all these times?
I know how she felt.
And that's why I felt like I had to apologize to her, because I said sometimes we just get overtaken with treating the fact that you're not breathing well, and we need to do something about that.
Sometimes he'll go like that. And like when she reaches for the tube or whatever, and she looks right at him, and it's like she just looks at him as if to say, "What are you doing?" You know, like
right.
she's trying in her own way to subtly indicate to him, because it's obvious she's been the strong one and is trying to help him.
Right.
She's trying to help him deal with her death.
Exactly.
It's amazing.
And that is the dynamics of their relationship. I mean, that she really has always been strong, and that he is absolutely so devoted and at a loss without her. That to have her even be like this, to come to see her, to at least have her be alive, is better to him than anything else.
I agree.
And that's where the problem is going to lie, especially if she crumps.
Yep.
Once she gets extubated, then the choice is made not to reintubate.
When she takes a turn for the worst, I mean, who is he accepting death when he's running to grab a stethoscope to listen, or the blood pressure dampened out on the thing? Oh my God, her blood pressure, and it's like he wants somebody in there to fix it right away. And
Meanwhile, he hasn't come to
can't.
terms with the words that he said, "No, I don't want to resuscitate
he
it." But
hasn't.
I said the event of a cardiac arrest for Bernice is so minimal. A respiratory,
That's why he could do it.
Right. And that's why we got half of what I call a code status.
Right, but
It's really-
denying somebody a tube is a lot different from defibrillating them once they've stopped breathing or their heart has stopped. It's
Correct.
totally different.
It's totally different.
Especially since he's a physician and he realizes to his own extent the difference between the two things.
Correct.
You know,
That's
but
right.
I'm glad you said something. That was wonderful.
Well, thanks, Sue. I appreciate it.
I spoke with Mrs. Factor, and I've written a note here. I had a long discussion with Mrs. Factor, which revolved around two major issues, tracheostomy and reintubation. Mrs. Factor feels quite strongly that she does not want to have a tracheostomy, even though she realizes she will die if she comes off the ventilator and is not reintubated. She's been reintubated 5 times in the past 2 months and feels that she has been through too much already. She would also prefer not to have been intubated at all the last 2 times that I have seen her this month. Given her wishes and the hopelessness of the situation, I think her wishes are reasonable. And we'll discuss this with Dr. Curlin and develop a plan that incorporates Mrs. Factor's wishes. She made it pretty clear that she put it, she thinks George is crazy.
Is that what she said? How did she communicate
How did she
that to you?
communicate
I'm
that?
just curious.
She mouthed the words. I mean, I almost cried in here, I tell you. I think she's more difficult for me than this lady. This lady's dead already. You guys are flogging yourself, but she's gone. You know, Bernice is a lot harder problem. It's a lot harder to walk into somebody's room who's, you know, awake and alert and say, you know, these are the options. You know, life in an institution with a tube in your throat, on a machine, or you can die tomorrow. She had it much easier. She didn't have to make the choice. It happened real quick. She was out. She's going to be gone. It's a much better way to go. I mean, look what's happened to her. She's been around for 2 months. Doctor hasn't told her what's going on. She's been intubated 5 times.
Yeah.
I had a conversation with Mrs. Factor this morning.
Yeah.
She is adamant about she wants that tube out and she does not want a tracheostomy.
Well, that's her privilege. I rather thought that that's what she would say.
She's quite she's
You have to know
very
be-
upset that she's
I think when we reintubated her yesterday, she just was really furious.
Before she entered the hospital, she set very rigid limits to her care. Limits which were
Unreasonable.
not in her own best interest.
right. I'm sure that's probably true.
Always bargaining to accept the lesser of 2 therapies. In part, that's one of the reasons that she has been so ill. Not her stroke, which is a major, but with regard to other aspects, both her heart failure and her chronic lung disease, her overweight and her obesity and
Wouldn't
hypertension,
let you do
always
that.
accepting the minimal amount of therapy, and that only after pushing and compromising. And as you know, her husband, though a physician, was never able to get her to agree with more than she wanted to, because she was the dominant member of the family.
Well, you know, I mean, I have to say, sort of looking at the situation now, it's probably not unreasonable. I mean, if I were, it's hard. You never know what you'd do in that situation. It's really hard to say. We'll try again to wean her tomorrow. I think.
That's the last crack, you mean?
Well, no, I mean, I think I'm not so pessimistic in the short term. I always get them off, but I mean, I don't know, can't guarantee that she's not going to have to, that she's going to last for a long time.
But see, the problem is she's going to be left with the stiff ventricle.
Right. But I
And-
give her some diuretic before, and, she doesn't want it back in, fine.
I mean, in terms of what's likely to happen in the near future.
Well, I mean, it's, we're talking days to, at the best, days to, weeks. I mean, because she's going to reaspirate too. I mean, I don't, it's no. I mean, I think she made it very clear that she knew that this meant that she was going to die.
And I think she does.
Yeah, I mean, she understood that very clearly when I told it to her. And I asked her, I said, how does you think your husband will feel about this? And she said, he'll accept it.
But he's having a very hard time living with this. He came over to my office yesterday afternoon, and he didn't have an appointment. I said, "What are you doing here?" And I indicated that I knew what was going on and what it had. And he says, "Well, I just wanted to talk to you for a minute." But I think what he really wanted to know was, did I really know and understand everything that was going on? And I think also he just wanted somebody to talk to feel that somebody knew how he felt. And that was...
Well, I mean, I think that, probably the way to deal with him is to just say, look, talk to her. And, this is what she wants. This is what we're going to do. I think we've done everything we can, and
It'll be the...
Yeah.
He understands
yeah.
that. He's
No, I
ready.
think
He's ready for that.
Yeah, I think so.
As is the family of this man.
Okay. Well, I don't sort of know him well enough. I mean, maybe we'll get him off. What do you think? I mean, he seems like he'll do okay.
The last 2 days he had been going so steadily downhill on maximum therapy. You don't forget he's on 60 milligrams of prednisone, on large doses of bronchodilators, adrenergic stimulators. This has been going on such a long time, and it's like her, a combination of cardiac failure and chronic lung disease, that I'm very pessimistic.
Well, it sounds like his family made it pretty clear that they did not want things, super aggressive things done for him.
Again, there are strong resemblances between the two cases. He himself is the strong member of the family. He runs it, and there's a good deal of resentment among others about the amount of care and attention that he has required, particularly with people not blood relatives, but to whom a lot of the responsibility has fallen. It's not easy.
Okay.
I know how unhappy you are that the tube had to go back in again. But I was concerned that you were getting so tired yesterday that even though we could expect good results, you couldn't do it by yourself. I also know that this is against your long-term wishes. And Dr. Weiss and I have had a chat about tracheostomy, and I've explained to him that you are a very intelligent and strong woman who has always known what she wanted to do about her own health, and that your wishes would be exactly what we would live by and would be our guidelines. That's what you want, isn't it? Okay. I anticipate that we will be able to get this tube out and that you will be able to breathe the next time without it. You just got congested fairly quickly after it was taken out last time. I think we will do better next time and you will breathe easier. Do I understand correctly that, however, that if you should tire a lot, then you don't want us to put back in again? Is that correct? Do you understand what I'm saying? Okay. If you should tire after we take it out next time, we'll have two choices. We can either leave it out, or if we think you would benefit by it, we could put it back in. Right? Okay. Would you want us to put it back in again if you start to tire without it? Would you like to think about it first before we make a final decision? You know, we've known each other a long time, and you can be perfectly honest in telling me what you want, and I will abide by your wishes. Okay? All right. You think about it and let me know. Now let's see if you can breathe against the machine. Weigh in. Weigh in. Good. I'll come back later. You think about it. We'll talk again before we make the final effort to take it out, so we'll understand each other completely. All right? You tired now? All right, then doze off, and I'll come back and we'll talk again later.
Thank you. I just want to make sure that you understand what the options are. And Dr. Curlin explained that to you very nicely. If, in fact, we're able to take this tube out and take you off of the breathing machine, would it be your wish to not go back onto it if, in fact, you were becoming tired and needing the support of a respirator? Okay, that's the question. Now, you've been on it quite a few times so far, so it's not that you don't know what it's like. But it's very important that we understand what you want so that we can oblige and go by your wishes. Being that we're working on trying to get... You paying attention to me? Being that we're trying to understand what you want is so important for what's going to be with you. I know it seems like everyone keeps asking you the same questions and how many times do we need to hear it, but that's what we do. We like to hear it to make sure that if you change your mind again, that we know about it. Okay? So I'll let it rest for now? Okay. You ask me anytime you want to. I mean, I can understand you pretty well most of the time. All right? Okay.
Ana, ¿eso lo necesita? No, pero menos la...
Dr. Coleman and Todd couldn't quite get her to have the same blatant yes-no response to things, and he left it with her that he would get back with her later in the day, and then she ought to think about it.
Okay.
So,
Okay.
and I could have went over it again with her, and she's kind of irritated that I keep doing that, and so I said, I'm going to leave it alone, but I want you to stop us at any time if there's something you want to know about or you want to discuss it. And we keep asking you because we want to make sure that you always have the option to change your mind.
Right.
So that's where we're at.
Okay.
In lieu of yesterday's events, and after minor discussion with Scott, in which he really felt that the reason she failed was because of failure only, and my feeling was that from Sue and from what I looked at the flow sheet, that it was a combination of increased sputum production as well as failure, and it wasn't water from failure. She has had increased sputum production at least 24 hours prior to that when I was here on Tuesday, acutely.
When Katie heard that she got x-rayed last night, she was like...
Forget it. Well, anyway, to make a long story short, after evaluating her, and having had the word trach was mentioned yesterday both by Scott as well as it showed up in Dr. Curlin's note as well. Scott said, why haven't we ever asked Bernice what she wants? And we all kind of looked at each other and said, well, why don't we? My feeling in asking her what she wanted was a few things. Number one, 8 o'clock, 9 o'clock in the morning is not her best hour.
time.
I said 11 would be better. She tends to take a slow day waking up. Her mechanics never are great in the morning. Not that they're ever great, but
She's
you
not a
don't get a
morning
good
person.
effort. Right. My other feeling was like, okay, so what if she's able to articulate in whatever form that she can that she isn't willing to be trached and would like to be extubated and not reintubated, for instance? What gives us the feeling that, number one, Dr. Curlin would also feel like that's a good idea and want to go along with the situation as well as her husband.
Right.
And at that point, I felt like it was a great idea to ask her, but once we had asked her and got a good idea from her, then everything had to be focused through Dr. Curlin. I don't think that by any of us that Dr. Factor needs to be approached by house staff, nursing, even Scott, unless George Curlin gives Scott the...
It was only appropriate in that instance.
In that one setting, because we were talking about a very acute demise.
Right.
And I just said, for the sake of all of us that have to care for her daily, for us to be the one to go to him with something that he hasn't heard from George Curlin would not be beneficial to the situation as a whole.
At all.
To make a long story short, Scott went in after rounds, talked with her, called me into the room. He wanted me to sort of interpret and watch him
It's hard.
talk. And I will tell you, I've never seen Bernice be quite so definite. And it was as clear as day, her answers to all these questions. And Scott went through the gamut by saying that these are the choices. We're finding that you're having problems with your heart in terms of going into some congestive heart failure and having your lungs fill up. We also find that because of the fact that you've had a stroke and your cough isn't good, that you have problems with pneumonias, and that these are problems that you probably will have throughout the duration of your life. These are the choices we want to present to you, and we want to know how you really feel about these choices so that we can better help negotiate your care. When explained about the trach, the answer was definitely no, with a shake of the head, with saying that she didn't, with the hand, saying the word operation, the fact that there would be an airway in her neck, and if we needed to put her on a ventilator as we needed, that there would be a way to do that without putting a tube down into her. Then the other choice was that we would try our best at this particular point to improve her pneumonia and then be able to take her off the tube and make her comfortable so that her breathing should be easy enough that she would be comfortable, but that if in fact she tired and seemed to need the tube back, that we wouldn't put it back if she didn't want it back, but we wanted to talk about it now.
Yeah.
And
Why'd you say that?
we had to break that up because that was
Yeah.
kind of a long
Yeah.
story. First, I started by saying to her, all the times that we've put you on the breathing machine, have you wanted to be on it? Have you wanted to be on it any of the times? No. I did say to her, do you realize that you've been on it
6 times.
6 times already? Yes. Then we went on to say, do you realize that even if we make you comfortable off of the breathing machine, that if you need it back and we don't give it back to you because you don't want it back, that you probably will die? Yes. Is that acceptable to you, knowing that you probably will die if you need it back and we
Don't give it
back?
because you don't want it.
Yes. Do you want it? No. So I felt like we broke up the concept in 4 or 5 different ways so that we'd be able to decide.
You applied it in different
Right.
situations, and
We'd
she
be
said
able-
no to all.
right.
She was
All.
consistent.
She was consistent. We told her that we would do our best to make Dr. Curlin aware of her wishes and that we would go to bat for her in terms of Dr. Curlin as well as with her husband. And then I did say to her, do you think that your husband will be able to support you in your decision? And she said yes. And we left it at that. Dr. Curlin came in later on, had a similar discussion with her, and she wasn't able to give quite as snappy of a yes or no answer to what he was asking her, which was the same things that Scott and I had talked to her about she wasn't given a lot of time either. I mean, you know, Bernice, she's not real quick with her answers
She
unless
has to
it's
be
a
very
definite.
patient.
Right, you have to be patient to sort of give her the time so that she can make the effort. And because she wasn't real snappy with her decision, Dr. Curlin did say to her that he understood how she was feeling and that he really thinks it's an important decision and that she give it some more thought and that he would be back later in the day to discuss it with her again. Later in the afternoon, the plan as it stands right now is that if we don't see Dr. Curlin by around this time, that Karen Ballin would call him and say that we would really like to take the time to get together with Dr. Factor while his son is going to be here through Sunday, and also because we plan to continue the weaning process as her pneumonia improves, that we need to sit down and talk with them now. If it's something that he doesn't have time to get into or he hasn't had a chance to speak with them, being that he's been rounding all day, that he needs to let us know that. And Scott is going to be up later in the evening and would be glad to be involved in actually holding the meeting or be there when Dr. Curlin speaks with them, but that we need to all sit down. So a sort of impromptu family meeting, whether it's today or tomorrow, but we feel like we need to get the ball in motion.
Yeah.
And that's where we're at.
I guess there's just sort of a lot of issues about, you know, what are we going to do? Should we try to take the tube out tomorrow and see if she flies?
Well,
if she
I think
doesn't
we ought
fly,
to, as long as
put
it
her
is.
back in, or?
Well, that is something that I agreed I would rediscuss with her,
Okay.
because although she apparently, Scott got the impression that she said to him, enough, I don't want to be reintubated. But when I went in and took it up with her this morning, I was by no means convinced that it was clear in her mind that that's what she wanted to do, and I left it with her to cogitate it a little bit and then decide. So I think that that'll be something that we'll take up with her again. In any event, I hope that if we get her dry enough in advance, that we will at least get it out with impunity. Then the issue of putting it back in again will be another matter.
Okay.
You know.
Because I guess the son is only going to be here till Sunday, so it would be nice if we could, you know, have his
I think we
input as
ought,
well.
you know,
Yeah.
get her as dry as we can, and then bite the bullet.
Okay.
Okay.
We need to talk to you and find out what you'd like us to do about the tube. Okay, the breathing tube.
You tired of talking about it?
We want to find out what you want to do. Okay, you're the boss.
You don't know? You're not sure what... Well, remember I told you yesterday what the two choices were, basically. I mean, I think that we can try to take the tube out and not put it back in the way we did this last time. But there's a good chance that if we do that, you may die. And I think the other possibility is to do an operation and to put a hole here and put a permanent tube in here. Okay? Do what's called a tracheostomy. And when Ann Louise and I, the nurse right over there, when we talked to you yesterday, I got the impression that what you wanted to do was to have the tube out and not have it put back in. But it's important for me to know what you want, because Dr. Curlin's going to come back here today, and he's going to want to know too. You don't know. It's hard for you to make up your own mind. It's a tough choice. It's a pretty tough choice. You're right. It's not a good choice. I mean, I think that it's very important for us to do what you want, and I think that knowing those choices, okay, it's hard for somebody who's not a doctor to know what's the right thing to do. And I think a lot of it has to do with how you feel about what's happened so far in the hospital. My sense of things is that if you really want to go on, and you want to live, and you want to keep going, that the tube here is the thing to do the tracheostomy. sorry, I didn't catch that.
Are you saying
Mrs.
that
Factor.
that you still can't decide between the two, Bernice? Is that what you're saying? Okay. Do you need more time to think about it?
All right, well, that's all right.
It's all right.
You got as much time as you want.
Is there something that we can answer about either of the options more clearly for you?
Is there anybody that you would like to talk to about this that would be helpful to you?
No.
What are your worries about it? Don't want to die? Not worried about that? Worried about your husband? How he'll take it? I mean, whether he'll get upset and have a heart attack or something like that? Well, it's a possibility, I think. I mean, it's possible that he won't take it very well. I mean, it's hard to know, you know. I mean, I think that that's a real possibility that he won't take it very well. I think that there may be things that we can do to, I mean, either way, either doing the tracheostomy or not doing it, he won't take either one very well. Or that he particularly wouldn't take your wanting to call it quits. Which one?
Is it calling it quits that would upset him, Bernice, more than having the operation? Either one?
Either one.
It's going to upset him.
Either one is going to upset him, yeah. Well, you know, there's not a lot of good answers here. Unfortunately. But I think that, if you want to go ahead and have this tracheostomy, that's not, the end of the world kind of a thing. I mean, it's a small operation. It's not a big operation. But it would mean that there would be a permanent tube here. All that this will do, this operation, will make it easier to put you on the machine. Make it easier for you to go on the machine. You have to go on the machine. That's what it'll do. It's not going to change anything with the stroke or with the breathing, because those are problems we can't really do much about. They're sort of there, and they're going to either get better on their own or not going to get better on their own, as the case may be. You with me? Are you with me there? Did you understand that? You don't understand that. You do understand that.
Are you telling us enough? Yeah. Okay.
You just want to think about it? Yeah.
Just want to think about it for a while. Okay. We can't wait too long, though, because eventually we're going to have to do something about this, because it's been in for a long time.
Okay.
And sort of the feeling that I'm getting from you is that you're not sure whether you want to have the tube out or have the operation. I don't know what that means. You don't want to have the tube out, or you don't want to have the operation? No. You want the tube out. You want the... Do you want the operation? Yes. You do want the operation.
Is that what you're saying, Bernice?
You don't know.
You don't know.
Okay, so you want to think about it. You want some time to think about it.
Go away.
All right.
Don't feel bad.
Let me take a listen to you before we go, okay?
Yeah, okay. You got time. You got time to think about it.
They're going to listen to your lungs, Bernice.
Exactly the answer that I got from her yesterday. She was uncertain. I came in after my conversation with you and thought, well, she's made up her mind, but after I discussed it,
She hasn't made up her mind.
No, she has not made up her mind.
Not clear whether I think she's mostly worried about her husband. So it sounds like from talking to her how he's going to take it. But I think she's getting ambivalent feelings herself about it, too.
I have to admit, if I were there, I'm not so sure how certain I would be about what I wanted to do.
God only knows. Yeah. Okay, well. Richard's on this weekend. Okay.
Hi, friend. Other people go off duty, but your old friend is always around, so you and I can peacefully discuss this at some length. My understanding yesterday is that you weren't quite sure what you wanted to do about this business. Is that right? Okay. You take all the time you need. And I must say that whatever we do, we can undo it if we have to, too. These are not decisions that are cast in cement and cannot be changed. But on a nice day when the sun is shining, seems pretty good to be around. And Harry's around. I spoke with him yesterday afternoon. He wanted to be sure that I understood exactly what his feelings were and what he thought yours were too. So you just be confident that your interests come first with everybody. Okay?
We need to get her sort of maximally set up here so that, you know, if she makes a decision, she either goes for a trach on Monday, beginning part of the week, or, you know, we extubate her Saturday or Sunday and see if she flies on her own. And I can understand her ambivalence about it. I mean, you know, it's a difficult decision. Hard to know.
There should be a decision before we extubate her.
Oh, absolutely.
I mean,
absolutely,
I would not
absolutely.
extubate her until we knew what we were going to do
Absolutely.
after.
Oh, yeah.
I don't think there's any question about
Especially with our
that.
past track record.
Right.
Right.
It's important.
Okay.
So that's that.
Any other thoughts, George, you want to...
You know, my thought is that as she feels better, she is not quite sure that she wants to let go. Today she sort of has a certain spontaneity and a certain smile to her face, which she had a little bit of yesterday and zero the day before. And so maybe what she really is trying to say to us now is that I'm not giving up.
What about getting Critchlow to see her about a trach beginning part
Well,
of
I
the week?
think we ought to have him at least look at the issue and be prepared to go ahead, and then I'll...
We should make her decision over the weekend. You know, and then
I will... Dr. Factor came up to my office yesterday. Hard to understand what he was trying to say to me. He just came and he just sort of wanted to hold my hand for a minute, so he, as though to get some feeling, gee, somebody really knows what's going on and knows that I'm suffering. And that's literally all I did. And, so I think that he, rather than lose her, would certainly go for doing a procedure.
Okay.
Okay, thanks.
She's clearly, I mean, she's clearly giving us a different message than she gave yesterday. I mean, she said a totally different thing to us today than she did before.
Makes it hard.
Yeah.
Well, but I mean, as George said, you know, I mean, if that was me in that bed, I don't know what the hell I'd say.
He's pulling temper tantrums in the room that aren't based on anything because he doesn't know anything. He's teary-eyed, he's getting frustrated, he started yelling, and her arm, he was holding her hand and she was pulling him back and getting her upset. I can't have that happen in the room.
Can't go in there then.
But his son said to him, Dad, control yourself. And my feeling is I told George Curlin that the behavior needs to be addressed, and the longer we keep Dr. Factor in the dark about all these decisions that are being made, the worse this is going to be. And I can't take care of him and take care of her at the same time.
Why don't Karen and I can talk to him.
Yeah, but why don't you kick him out? I mean...
Oh, he did. He left
Okay.
and she was pulling him back. I said, Bernice, he has to leave.
Okay.
I don't want to fight with him because I am her caretaker. That's my concern. He's already ostracized one caretaker, and that's why I had to speak to George Curlin about this. So.
Well, I think that I'd like to talk to the son anyway, and Karen and I will talk to the son. I haven't met him.
Okay, well, sooner than later, because the father has probably gone up to OBGYN to have his coffee up there. That's where his escape area is. So anytime, the son is here and in the room with the mother, and I'm sure he would be glad to talk.
Did you talk to him at all about the discussions that we had yesterday?
I asked Dr. Factor when he went up to visit Dr. Curlin yesterday what was said. And he said, as George Curlin did, basically, I just needed a friend. I need to let him know how upset I am that my son is leaving and that I'm going to be alone again, and that the situation is too real. Those are his words. No discussions about anything concerning the tube. When he came into the room just now, Bernice and I were talking, and I asked her about this morning and whether she'd given any thought. No. I said, are you going to give it some thought? Yes. I said, would you like me to go over the things that you're giving thought to? Yes. I mentioned the options. He walked in and said to me, oh, what is it that Bernice wanted to talk to you about? I said, oh, the tube. And that was it. And he didn't get into it anymore.
Then he went bananas.
Then he held her hand, and then he went bananas.
Right.
I think his anxiety is escalating, and
All right, well, we can talk to the son in like 10 minutes.
I'd like to talk to the son anyway, just because I will be interested
needs
to...
to meet him.
Well,
In terms of,
I'd be interested in... Yeah, I think somebody should meet him, and then I can tell him that... Sure, who's the visit next month?
I don't know.
To find out who the attending is next month, but I can at least tell Schwartzstein who's on for the weekend, you know, sort of what... It's a really difficult situation.
it's very difficult. And he's in a difficult position because he hates to leave his father knowing his father is decompensating.
Right.
But I mean, you have to take care
Yeah, and I
of
can't...
her, and
right.
you have to kick him out, and, you know, I mean...
But just understand that the last time this all
I
happened
was
is
there.
because of kicking him out.
Right, but he also...
What happened?
He basically went to war with the nurse taking care of her when the patient was on her head getting dopamine, not doing well, and Colleen was pulled in two different directions, and he thinks he has dismissed her from the case. And I have told Dr. Curlin as well as Dr. Factor that nobody dismisses nursing from the case. Nursing can dismiss themselves if they don't think they're in the best interest of the family or the patient. And that's the case. But he can't continue to behave this way and decide how things are going to be handled in terms of care.
Right.
That's all.
Well, he can't, we have to tell him he can't go in there if he's going to abuse the nurses. It's ridiculous.
Okay, thank you.
Okay, thanks, Anna Louise.
Great.
What happened was, I mean, basically, that was the night she was doing really bad, and she was on pressors, and he would not leave the room. He was just, you know, just being a nuisance, and Colleen just had to kick him out, and we all said he had to leave, and then we were like ready to call security to get him out, you know, it was just...
He was running down the hall
Right.
like this with his hands over his ears. I'm not going to listen to you. I'm not going to listen
Right.
to you. Just
You know,
go
it was-
away. Leave me alone.
You know, and it was just a very bad situation.
Well, you know what Freud said? Neurosis is no excuse for bad manners.
You want me to fix the hand? Do you want me to lift it? Oh, yeah, it's a little swollen, but that will be taken care of. You don't need to worry about it. It's part of the sickness that you can't move the muscles yet. That needs more healing time, dear. More healing time. More healing time. More healing time.
I knew her when she came in the first time with her stroke and aspiration. I thought at that point that she and the husband didn't want this sort of prolonged course. So what happened in the meantime?
There's been a large debate about this, and currently she and her family are considering whether to get trached or just to bag it. And the husband wants her to get trached, and she hasn't decided yet what she wants. Is that
She's been addressed in the past 3 days, and she
was up to date?
She was a pretty convincing no to Scott and Ann Louise, and
2 days ago.
2 days ago, and yesterday Ann Louise did say she was more ambivalent after thinking it over for a day. When she talks to Dr. Kurland, he's not as convinced, but. You know, an hour after Scott and Louise talked to her, Dr. Curlin talked to her and still wasn't convinced of her wishes. It was uncertain whether she was as convincing to him as she was to Scott, or whether his interpretation of it wasn't, you know, whether he didn't let her answer, or, you know, It's been a debate, and also it's ongoing. Not things that the Sun will be here until tomorrow, and will help Dr. Factor cope with exactly what's going on. So hopefully we'll have.
And she's been debated for how long now?
Like
14 days.
7 times in the last 2 months.
Right, but this most recent...
14 days.
Active discussion really about tracheostomy versus no intubation has been going on about 4 days now,
Right.
where it's really been pushed on
Are you
all
pushed?
fronts.
Are you pushed to do a trach in the next
Yes.
couple of days?
No,
Or we
no,
have
I
to
mean,
really, or just
no, I
next
think, we can,
week or 10 days.
in the next week. I mean, this is, sort of silly to keep on.
I mean, she's
figure
basically been in the
down.
hospital for the last 4 months now.
Right, exactly.
She actually looks, in the next 24, 36 hours, I think would be optimal to extubate her, to give her a fair chance. I think Wednesday she wasn't given a fair chance. She was being suctioned every hour. She was still 2 kilos too wet. Now her weight's down to 63, which is what we're aiming for. Her secretions are down to suction her every 4 hours or so. But to give her a fair chance at extubation, but I don't think long-term our options are changing.
Right, and I think we need, when we extubate her,
we have to have a
plan about what we're going to do.
It's not fair to
The
her.
other issue for the long-term management of her is that maybe she needs a trach for bronchopulmonary hygiene and
I think she
prevention of
does.
aspiration.
She needs a trach.
But I think it should be
going to die.
I mean, even if she's not ventilated, that she needs
Right.
a
Oh, I
trach.
agree, right.
But I think she should have that option, and not Dr. Factor. And that's what was stressed yesterday, was that she was our primary concern. Not that he wasn't, but she was our primary concern.
But I think that she has a lot of ambivalence about.
I believe, yes. But I think she has a lot of ambivalence about being reintubated. I agree with that. But I think that tracheostomy should be explained to her fully and completely. To say that, number one, it's not a cure. Number two, she's going to stay just like this, but easier to put her on and off the machine. Now, if she wants that for the remaining of her days, that's her decision. But I think that has to be explained to her and said, I mean, it's not like she's going to get, her paresis is going to resolve because she's got to, which, I mean, she's not a stupid woman either.
No, she's
and I think that could be very,
the leader of the family and so on.
I just think when that's addressed, that's important.
All right, well, I'll talk to Dr. Cohen again.
The good things are that you're breathing better and your lungs are clear and your heart is breathing slowly and regularly. And the bad thing from your point of view is that tube is still there. But after we get enough water off, and you've had a couple of really good days, we'll try pulling it out and see how you do without it. Okay? Good.
I told him, I said, I'm answering the page. I said, right, Karen wanted it.
Jane talked to her yesterday about sort of her wishes and her plans for the future, and she expressed a desire to be trached, even if it meant that she would be institutionalized for the rest of her life. That would mean an institutional existence in a nursing home
You know,
or a
I gave her the
hospital or
conditions
something.
of, never going home, being in a chronic facility, living out the rest of her days as she is, not getting any better. And she said, that's okay.
All right, well, then I think at least...
Yeah, I mean, we have consensus, and I think Dr. Carl,
And you thought she was pretty
she was pretty clear.
awake yesterday. Well, I don't think that this sort of question needs to be, sort of readdressed then every 24 hours. I mean, she's at a time when she's awake.
No, but she was originally dressed on Thursday, and she's been thinking about it, and her thing has changed, and I think it's good to clarify. Yeah.
And the son's going to leave today, right?
I assume so. I don't know for a fact.
Good. Because then it becomes obviously trivial to wean at that point when she has a trach.
That leads to my next point, which is that we were talking about trying to wean and maybe extubate. Tried to extubate this weekend, but we didn't want to extubate her until we had a plan about what was going to happen. But now I think it's silly, and we should just wait until she gets trached and then try to wean her.
It sounds good.
So she can either, I guess we could still put her on Briggs and exercise, or give her some. That sort of thing, but in terms of being really vigorous and trying to get her off the ventilator, I don't think that's appropriate. She's going to have to be on the vent to get her trach.
How are you this morning? You look a little worried there, are you? Hey? You frightened about something? About this procedure that they talked to you about? Is that what's worrying you? Let me explain it to you a little bit. 2 or 3 times now, when your breathing has suddenly become very difficult, we've had to put that tube down your throat to help you breathe, right? Okay. We're about to take it out again because you've done well after the last episode. But we're concerned that if we do and we have to do it again, it'll just irritate your throat a great deal from going in and out. And so the lung people, the pulmonary consultants, have suggested that we do what's called a tracheotomy, a tracheostomy, by making an opening here, which will give us an access to your airway so that we can suction it out so that the breathing can be easy. This does not have to be anything permanent. In the past, we have closed these over with some people. Is everything that I've said clear so far? Okay. Now, I think the important thing is that nobody will do anything to you without your permission. So what you have to tell me is, does this make sense to you to go ahead and do this? What do you think? You're not sure. Okay. Do you want me to decide for you? Okay. I think we will, because Dr. Schwartzstein, whom you know as a lung consultant, and Dr. Weiss, who is the senior lung consultant and was on this ward for a whole month, both think it's to your best interests and will provide more comfort for you and ease in taking care of you compared to having this tube in your nose and down into your airway, or down in your throat into your airway. These tubes will come out after the procedure, so there'll be some payoff for you in doing it. Is everything that I've said clear to you? These are our options at this time. We'll talk, and in the meantime, we'll try and arrange time in case we should all agree that that's the right procedure for us. Okay, good. See you later.
I mean, he's always on the side of letting him live.
Well, if it's
doing everything
he is
you can.
ageist. I think he also is ageist. It's hard not
But
to be when you're young.
Look, he's a layperson.
But that's the point.
Just
He's a
like you would not. I mean, you're supposed to know your business, okay? What does he do? He's a lawyer.
He's a lawyer.
He's a lawyer, right? I mean, if it came to a tort case or whatever, and he said, Rachel, we have to do this, this, and this. You would ask him some questions about it, but he's the professional, not you. Whereas your job is to interpret all of this stuff.
No, but you see, if I came home and I said, I have this clinic patient, she has this Hopeless tumor, there's like 1 in a million, she's 35 years old, she just had a baby, and I can't see putting her through the torture of chemo. His response would be, that's not your choice, that's her choice.
Well, I think that's partly right, in the sense of saying, that
she should choose the chemo.
Well, that she should have the choice of understanding, making an informed decision about. I mean, this gets into not the question of sort of DNR, but sort of what is the physician's responsibility? What is an informed choice, and what is, I mean, the problem is that, it's always informed in quotes. It's yes, we can cure your leukemia, but you're going to have to spend the next year in the hospital, and people are going to stick needles in your body every day, and horrible things, and you'll be tortured in ways you never dreamed could possibly occur. But you will live. Some people would say, well, that's the definition of purgatory. And some people would say, no, I take my chances, I'm going right to heaven. Do not pass go, do not collect $200. I mean, the question is, what is informed?
Well, that's the thing. saying, it just strikes me how, as this layperson who's sort of, lived with me through medical school and all, he still always comes down on the side of the hope and the chance, even though, he's heard quite graphic descriptions of the chi-chi that goes on. And so then when I say, he says it should be her choice, and I say, yes, but, who's giving her the information to make that choice?
That's right.
It's me, and I cannot help. My bias must come through. I'm human. I'm not a computer. And
Well, right. I mean, I think it
So
is
then
important as long as you realize that that. I mean, I think there's, as much as doctors try to be objective,
it's impossible.
Nobody's
It's impossible
totally
to be.
objective. I mean, and we slant the news and sort of say, look, I think you should do this and this and this. Well, I am quite nihilistic about what actually happens. I mean, I think that from a personal point of view, I mean, I think you do real well with the infectious diseases, and if you can exercise, keep your weight down, don't smoke.
Easy.
Then you've done everything. Then you've done pretty much what you can. But a lot of this stuff that goes on is just not really relevant to making quality of life or length of life all that much better.
If you want to
But that's part of me.
give people quality of life, you could be a furniture salesman or something. It's easy to fix things that are fixable.
Well, it's really rolling the rock up the hill and having it come back down again. That's a lot of what this is.
The instances when it's important to start raising the question about withdrawing or withholding or stopping treatment. I'm going to use the phrase raise the question a lot, because at no point in this discussion, because this is all theoretical and hypothetical, am I advocating in any of the instances I'm going to talk about that it's absolutely the right thing to do. There is never an absolute in these situations, because the clinical contingencies as well as people's moral and religious feelings have as much to do with these kinds of decisions as any theoretical basis. All right, so having said that, let me proceed. There are probably 4 instances, kind of general situations that we confront, particularly in critical care settings, but throughout interdisciplinary clinical practice, where it's appropriate to raise the question about stopping treatment. The first of those is very easy, and it has to do with what we talked about last week. When the clinical diagnosis of brain death has been made, any of the support therapies that have been initiated can and should be stopped. That seems fairly obvious, and probably is fairly obvious, but we've all been in the situation where we find ourselves, or we are working with physician colleagues who ask families permission to turn off life support systems in the event of a brain death diagnosis. I think a combination of things result in those awful situations where patients' families either can't digest or can't accept or can't understand the clinical diagnosis of brain death, and therefore have a difficult time going along with the termination of life support systems. For one thing, we as clinicians have to accept a lot of the blame ourselves. As we said last week, we tend, when we go out to talk to patients' families, sometimes to soften the blow with euphemisms that only confuse the issue. Even saying brain death as opposed to death sometimes confuses the issue, because we imply that the person isn't really dead. And while the diagnosis of brain death is made differently, and there's a different clinical picture than physiologic death, as the distinction has been made, dead is dead. And as hard as that is, it's more compassionate if we kind of give all the bad news at once and then rally all of our resources to support these patients, the families, rather, through this horrendous news, rather than thinking that we're buffering them from the ultimate hurt and really confusing the issue and either giving them false hope or presenting them with options that are not options.
are you holding up?
I'm fine.
Doing all right?
I tried. Yeah, it's hard, but
Okay. Is there anything I can do for you?
no.
Okay. Have you been using the medicines at
No,
all?
no.
Okay. Well, if things get to you, you can use them. Did Al give them to you?
No, he's waiting, but I try to be calm and I want to feel everything right now. I don't want to, take some pill and feel, something different. I want to feel wherever they come, wherever they come.
Okay. All right. Okay. Anything else?
No.
Okay. I'll
Thanks.
see you tomorrow then.
Okay. Thank you, Dr. Jones.
So let's figure it out.
We're just listening to your lungs.
Mr. Carver, how are you doing? Any pain?
No.
No? Good. Still got that flush in his mouth, huh?
I'm just going to test this and make sure it doesn't look bad.
I plugged his morphine in his saline line, Sue.
Excuse me?
I plugged the morphine in his saline line.
Fine. That's fine.
Since last night, he's had really a deterioration. We're not sure exactly what's going on. He continues to have episodes where his blood pressure drops.
That's the first time that happened today, right?
Pardon me?
They happened this before?
It's
Only
happened since
today?
last night, just today. I mean, since early this morning, sometime during the night. He's had episodes where his blood pressure drops and where sometimes his heart rate drops as well. And the amount of oxygen he's getting into his bloodstream is less than usual, and you know that it's already not very much. Are you his wife? Yes, that's what I thought. It's already, not, he doesn't get enough oxygen into his bloodstream. But these new episodes where his heart rate and his blood pressure change, we're not sure what's causing those. It may be an effect of having prolonged periods without enough oxygen. It may be something else going on, but we're not sure. It's not surprising that a really prolonged course like he's had, in which he's been critically ill for a long period of time, that he should now become unstable. But that's not surprising, and that's really what he's doing now. And he's never had problems with his heart before, and I think the problems with his heart really reflect what's going on with his lungs.
So what's going to happen now?
Well, I don't think I can tell you what's going to happen to him, and we're trying to find out exactly what's wrong. We're going to get another chest x-ray. We've gotten EKGs, and we're sending off blood cultures to see if there's an infection, but so far those have been unrevealing.
Should let me know, anything, what the results on it.
Okay. I know you understand that his overall prognosis is not very good. In fact, it's very poor.
Yeah, they told me everything, and I wanted you to be straight. Tell me whatever it is.
Okay,
I can handle it.
I think we can expect, given what's happened to him so far and what the course of his disease has been, I think we can expect him to continue to get worse, and this may be the beginning of a more rapid decline. We can still look for treatable causes and try to reverse it, but it may not be anything reversible. There may be very little that we can do in this situation. As I said, we'll keep trying. And above all, we're trying to keep him as comfortable as possible also. I know that the doctors that you know a little bit better have brought up the issue of whether he should be resuscitated should his heart stop. And that's something that the family needs to think about again, because now he's starting to show signs of his heart having problems. If that gets worse, it may come to the fact that his heart will stop, and that there's very little that we can do except we can try to restart his heart with very heroic measures like using electric shocks and pounding on his chest. But in his case, that's not going to change the overall picture at all, and it's not likely to be too successful. But It's something that we need to bring up with you again. I know we've brought that up before, and you may want to talk about it and then talk to us about it again. It's a very hard thing to bring up.
I don't know.
Yeah. Okay, why don't you talk with the rest of the family, and we'll continue trying to get his blood pressure stabilized now.
Okay.
Okay?
Okay, thank
And
you.
we're doing all that we can for him now, as I said. We're trying to find the cause of this and trying to treat it. It just may be the end of his disease, and it may not be something treatable. And I want you to know that, and we're not giving up on him or anything, but I think you need to understand that.
Okay.
Okay?
Okay, thank
We'll
you.
let you know when you can come back in.
Okay.
Okay.
The only thing that I really could think of is that, he's got some autonomic dysfunction just because of vagal nerve irritation. I mean, no other explanation really fits very well.
I know. That's the problem. Nothing really fits. There's definitely a change, and I don't know what it is. His mental status is different also.
He's much less
He's not responsive.
He was less responsive this morning.
And they keep backing off on the sedation, and he's still not responding. In fact, becoming less responsive.
I think from a practical point of view, basically, our options are to, give him fluids and then use pressors if he needs it. He's been, the last couple of days, his weight's not changed a great deal. He's been sort of even. He probably has some sensible loss in addition to what they're measuring. So he may be just a touch behind.
And we just gave him a unit of blood in addition to fluids, and he did this after that. We can keep, pushing on that.
Yeah, it took us a few liters to catch up the other day.
Yeah.
So I pushed
I
us
have a
little
feeling
bit
that's not going to be it. I saw the family, and they had actually been in the room when this happened. The wife was in the room, and I just told her that he was deteriorating somewhat, that he was becoming a little bit unstable, in terms of his heart, and that it might be something we could fix, but it might be just sort of the end stage of everything that's gone on and the result of the disease in his lungs, and she understood that.
Yeah, I've tried to prepare her for the fact that he's on the edge. And even very small changes are going to make a big difference. And I think that deep in her heart she understands that, but I'm not sure she really wants to believe it.
Yeah, it seemed like she understood that.
You talked with Dr. Rosol inside, and she had called me, and I came by to just have a brief look and talk with her. He did the same sort of thing about 3 days ago, but only for a couple of hours, and then it went away. His blood pressure dropped, and his pulse dropped, and then it went away very quickly, and we never knew why it happened. But this has been going on off and on for most of the day. It's had times when it's been better and times when it's been worse, and we don't really have a good explanation for it. We've given him some blood, we were giving him some intravenous fluids. None of that so far has made a very big difference. He may be a little bit better, his blood pressure is up a little bit right now, but I'm not sure that it's really been any substantial change.
How long? It's maybe because the transfusion.
Well, I don't know if he's gotten better because of the transfusion or not. He hasn't gotten substantially better. I think the point really is that he's not as well as he was, let's say, yesterday. I don't understand why there's been this change. His oxygen levels in his blood are basically the same, but for some reason or another, his heart just slows down and it pumps less hard, and his blood pressure goes down. And it's a worrisome type of thing, and it's worrisome in particular when we don't have an explanation for it, when we don't understand it, because then we don't know specifically what to do to make it better. From a practical point of view, what we will do is give him the fluids and give him the blood. And if necessary, we will give him some medicine to help stimulate his heart. Those medicines have their own problems. They carry their own risks and dangers. Our concern is that if we can't find an explanation for this, and the medicines and the fluids don't help him, that, you know, we may run out of things to do to help him. I just want you to understand, you know, that he's really very much on the edge, that he doesn't have a lot of reserve. But as we've talked about before, you know, we'll do what we can. You just need to understand that it's obviously a very critical situation.
Yes, I understand that now. I'm aware of everything. And I wanted you told me, you know, straight whatever it is.
So, you know, I've talked with Dr. Brasol, and we have a plan for the evening, and we'll just try that. See how it goes. All right?
Okay.
Do you have any questions for me or any other thoughts?
No, it's this in the medicine, you know, whatever you're trying to do, it doesn't work, you know, nothing can.
I don't think there's anything else we could do to stimulate his heart and get it pumping harder than those medicines. I mean, they're very powerful, potent medicines. But I don't think that there would be other tricks that we would have that we could use, you know, to help him out. So that these things really have to work for him.
If the medicine works, you have to continue to give it the medicine every day, or?
This medicine would be given intravenously, continuously. Okay, it would just go in him, you know, right around the clock. Okay, it's not medicine that we would give one shot of and see how it did. Okay.
How he's now? His blood pressure getting higher?
It's a tiny bit higher, but not very much higher. It was 77 and it's 82 now, but that's not really a big difference. And I'm not sure that's an indication that it's getting better. In fact, I think it really has to be viewed as just being the same. We're going to try more fluids and more blood first and see how he does. Okay. I assume, as we've talked about before, that you'd like us to continue to do what we can do.
Yes, yes. She told me about the shocks.
Yeah.
You know, but I can't make that decision. Okay. You know, it's hard to say. I can't.
I understand.
So I want everything, you know, to help him.
Okay. We understand, and we don't think that that's an unreasonable decision. We think it's a very difficult decision. We have a hard time with it too, because he's a young man, and he's otherwise quite healthy, and we'd like him to pull through. We're just concerned about his chances. But we will follow your wishes, and we will do all that, and we'll try our best. Okay?
Because I can't make that decision. I can't.
That's fine. Okay? Your decision is not necessarily a bad one. It's a hard one, but it's not a bad one. Okay?
Okay,
so we'll just have to see.
Okay.
Okay, and if there are any major changes, Dr. Brasol will call me back.
Okay, that's okay.
All right?
Okay, thank you.
Okay.
Get your chair so that you can sit by the edge. I can put that down lower. Today, his blood count doesn't getting high, and so they had to put in again more blood. And he hanging there. But nothing is changed, I think he's getting worse every day. Yes, I think so. Yesterday they told me, I had to prepare me about if they had to use, electric charge in case his blood, his heart start to stop. And they tell me I had to make that decision if they want to use it or not. But I can't do it. I don't know. I can't make that decision.
It's too hard and if he's too young, and I wanted to give him any chance to live. I know he's oh yeah, he's hanging there. He wanted so bad to live because I know he's he doesn't he hanging there, but I stopped. Yes, yeah, he's conscious. Yesterday I talked to him and I tried to encourage him, and he moved his head, and I know he was conscious in that time, but yesterday night he get it worse. And this morning when I come, he opened his eyes, and now he's sedated and sleeping.
Conceded at this point is to not shock him if he were to have a cardiac arrest. Okay. Basically, what I told her and what she would like is for us to do everything up to the point of shocking. In other words, continue to use pressors if he becomes hypertensive, to give him fluid resuscitation if he needs it, but not to shock him.
Okay.
If he were to arrest, I think that's reasonable.
Yeah.
At this point.
Okay, fine. So
I'll write an order.
Surgery center.
Yeah, and send him. He needs to have the trach. He needs to have a Hickman line.
Yeah.
Send him for those things.
Now, if he arrests, though, we do CPR, etc.
No.
Yeah, okay.
No. No. If he were to have a cardiac arrest, you don't do any CPR and you don't do any shocking. Okay, but if he becomes hypotensive, give him fluids and give him pressors.
All right. That does sound definitely reasonable. Okay.
I'll write an order.
Okay. All right. Thanks.
All right. I'll write an order.
Thanks a lot.
Yeah, thank you.
The other important thing for everybody to know why don't you tell me about Larry and the family?
Oh yeah,
Right.
he actually Larry spoke mostly with you. Maybe he told you the situation under which it occurred, or
Yeah, just briefly, he spoke with the wife at length, and she's comfortable having him not have cardiac resuscitation done should he require that. She said no shocking and no CPR, although she still would want us to be very aggressive about antibiotic treatment, pressors, etc.
Right.
everything short of CPR.
Well, this is, it becomes a little bit of an academic issue because that's not what's going to happen to this guy. That's not the way he's going to expire. If that's what happens, he's going to pop a bleb or just get septic. Well, it could eventually, but I think that it is important for people to know that.
Great pulse, radio, yeah. And all my pulses, good pulses.
Got a chest X-ray this morning.
It's interesting. I didn't want. I said to Larry Fabrizio yesterday in the rounds. I said, "You ain't gonna make it." Even before he came back from the Hickman, it looked worse.
You haven't been the first one to say that. You've been saying it for 3 weeks.
I think the problem with the attending is because it's a chemotherapy.
Right, I know. The guy is
complication,
quote a cure unquote
Right.
from subrenal cell carcinomas, and they're dying of iatrogenic complications. So
Right, and that
everybody
makes it so
feels guilty,
difficult to
you know.
accept that it's a very touchy subject.
I know, it's too bad people can't deconnect themselves from that. They get so invested in the treatment and everything. I don't know, young guy, but boy, what a horrible way to die. Larry's usually pretty reasonable too. He's not usually difficult to deal with about this kind of stuff. He's there's some of those oncologists who, really they border on fantasy land all of the time. Yeah,
we've dealt with one of them up there.
Well, the other night when he dropped his pressure, two nights ago or whenever it was, I guess it was 4 nights ago, I called him and he said, start him on pressors. Do this, do that. We didn't reach that point, but he clearly wanted it.
Well, I have a feeling that there's not we're sort of, when you can't find any place to put a line in the guy, and he's on gentamicin, and then he's going to get the antibiotic for the Andromeda strain. You're sort of talking the last ditch here. But I don't think Shulman is. At least he agreed to not having us pound on his chest, which is some small victory.
Major accomplishment.
She has one here in the family that's ready.
I would be inquired.
Wife, I've never met the wife. I know, but she come in and see him?
Yeah. Oh, yeah.
They have kids? How many kids?
Yeah.
3 kids. How
Did you
old?
see those heartbreaking letters up on the wall?
12.
9, 5. These letters up on the wall. Dear Daddy, I miss you so much. I pray for you to get better every day. Things like that. Heartbreaking. Yeah. Got me there at the police from yesterday. Going to.
But it's hard to know what to do at this point. I wonder. Well, the longer we keep him out, I mean, the longer we're sort of guaranteeing he's never going to, if he's got a chance, it lies in, getting his chest tube out, lightening up in the sedation, putting him on a TTs, he can breathe on his own, all that kind of stuff. If we don't do that kind of stuff, then he's just sitting there waiting to get infected, waiting to die. Now, I don't know. I mean, I'm not sure he can tolerate any of that stuff. I mean, I think we may be at the point here where his lungs are, so bad that, he's not going to. I guess maybe what we ought to do is just take some small steps. My own feeling is that if the chest surgeons feel comfortable taking out his tube, I would probably take out his tube. The reason I say that is that eventually he's going to get an empyema there. He's going to get an infection with this sort of a hole open to the outside. So, okay, he's not. He's been on the ventilator now for 3 weeks, and he's not been leaking for over a week. So, let's take it out. And then, I think you've got to see if we can pump a few more calories into the guy. See if we can feed him some more. And then I guess the final thing would be, once we sort of got that sort of under control, would be to lighten up on his sedation and see if we could get him to breathe on his own some.
Sounds like he is taking breaths.
That's been happening the past couple of days. But again, the ventilator, he's up to 30, popping off.
Oh, he's going to be, listen, when he goes on his own, he's going to, he's got no lungs there. He's going to be...
Well, that's what he's
Is there
doing
some
now.
amount of restriction and low lung volume over which a human cannot breathe on?
I'm sorry.
Can you measure that? I mean, could his lungs be so restrictive that it would be impossible for a human to ventilate those kind of lungs?
That's possible. In general,
that was my impression of the situation.
That may be where we're at. I think that that's the terminal stage of pulmonary fibrosis, which is basically what bleomycin is. It's a pulmonary fibrotic disease. So that in the terminal stages of any sort of fibrotic lung disease, CO2 retention is sort of a premorbid phenomenon. They just they run with a low CO2 because it's such tremendous respiratory stimulus from the proprioceptive influences of the small lung that they breathe, become maximally stimulated, and then when they just can't do it anymore, then their CO2 rises. And that may be where he's at, in which case, we have a sort of significant problem, because if we have to keep him sedated to have him breathe in the ventilator, then we're never going to be able to feed him, and it's just a question of weeks to months before he dies. And I think that overall, that's sort of where I see things being at. On the other hand, we're talking 3 kids here, so it's hard to... I guess what, we really, given that he's as sick as he is, and he's, we ought not to make a lot of sudden moves. We ought to do just one small thing at a time and not, jump in there and, really start flailing away with a lot of major league changes. So, I think that, kinds of things that you could do would be take the chest tube out, see if you could get a little more calories into the guy, small stuff, and then eventually gradually lighten up on his sedation and see if we can breathe for him. If we can still breathe for him with him getting less sedation, and if we, at some point you got to try that.
Well, that is in what they're trying to do now, and he has a heart rate of 150. And a respiratory rate of 30, and peak pressure 60 to 70. This is
so then
past few.
When they light him up.
They've decreased the morphine, I guess, over the past 24 hours. He hasn't been getting morphine boluses, just Valium, and he still has a heart rate of 130, and a respiratory rate of 24 to 30.
That's not so bad. Young guys, heart's
what we
okay.
want to go with.
We can tolerate a tachycardia in the setting of trying to lighten him up.
I guess I would try to do. Maybe the way to do this is to to take out the chest tube and see if we can feed him, get him a little stronger, and then start doing the stuff with the ventilator, and sort of not push too hard on that at the moment, and sort of put that off for a few days. I guess that's what I do.
Yeah, and it might help his semi-pneumonia too. First.
To the extent that he does have an infection, I'm not sure that we want to to rip him off the ventilator now. But I would vote for no sudden moves, you know, small things. Take the chest tube out, see if we can get some more calories into him. Don't lighten him up too much. Ventilate him until we get him to the point where, you know, we get the fever totally under control. Give him a couple more days of antibiotics, and then, you know, maybe the beginning of the week we'll try to lighten up, you know, cut back on the sedation and see if we can get him to breathe on his own.
Assuming the best possible scenario, just for my own
Yeah.
education, should he come off the vent and actually do okay and eventually even go home, what's the best he could hope for in terms of his functioning?
I can't believe we're looking at anything more than months here.
And months of survival.
Yeah.
And at best, he would
At
not
the
be able to
outside,
walk
maybe.
around very much.
He's never going to walk around.
Okay.
I kind of think the best we can hope for is chronic care. I'm not even sure we can get to that. I mean, that's the best. I think that's maybe 1 in 10,000, maybe even 1 in a million. I don't know. It's hard to say, but I mean, I just, certainly based on past experience, I think it's pretty hopeless. So, I mean, I guess I would vote for sort of just more of the same. Get the chest tube out, keep him on the amikation, and see if we can get some more calories into the guy. And we'll try the beginning part of the week to see what we can do about the ventilator, but I don't hold up a lot of hope for that. Be worth a try. Look, I've been wrong before, you know, you never can tell. Worth a try.
Yes, you can drink like that.
Medical intensive care.
No, I got him. I'm all set. Thanks. Are you an asking?
Hi. I got a call from Russell on the biopsy, and it showed fibrosis. There was no inflammation, nothing else.
His wife just wants us to, you know, she wants to play out the stream, so.
Well,
I think he did too. Just get 3 little kids. I mean, we're doing everything we can do. It's just not working.
I saw Dr. Schulman this morning just to update everyone on the family. He talked to Mrs. Cabry yesterday and sort of kind of gave her a very grim picture of how things were going and just sort of let her know in no uncertain terms that he was taking a turn for the worse and that, you know,
I think that's
his
important that she know
expectations
that.
were very bad. She still wants, you know, everything short of CPR done for him. She still wants all
Fine.
that done.
Not a problem.
It's been made very clear to her.
Yep. Not a problem.
Has he been on these steroids?
Since he came in, it's about
Is there
3.5
any,
weeks.
would there be any benefit of being
Thinking about
Then just wait over there.
That would be an asset.
Yeah, they told me that too. I checked with the nurse. Okay, good. Thanks a lot. Bye-bye.
I just reconfirmed all that with the wife, and she doesn't want any of that done. Take away the antibiotics, keep him on as much morphine and Valium as he needs, and, you know, not deal with his fin settings.
No more
anything else.
gases?
I wouldn't do any more gases or any more blood work. Yeah, okay, she's very comfortable with that, and I think we're all comfortable with the fact that he's just not going to turn around at this point. He's been intubated for 4.5 weeks, you know, and he's had his ups and downs, but it's basically been down. And it's really pretty inconceivable to me that he's going to get any better. And inconceivable to her.
Is she
All
here
right.
now?
Yeah. Yeah. She's out in the waiting area. All right. So I'll write a brief note and I'll talk to whoever's around.
Okay, that'd be great.
Okay. Do you have any objections or any problems with that?
Did a good job helping her.
Yeah, thank you.
Oh, yeah, because she's come a long way.
Yeah, well, you guys did a good job too. I know you spent a lot of time with her. She appreciates it. Yeah, she really is. She really is. And she's comfortable with the decision.
Great.
She doesn't feel like she's been pushed at all.
That's good. Good.
All right. So maybe I could just borrow this
Yeah,
for 1
sure.
second just to write a note.
Thank you.
Okay.
All right, so that's it.
DC antibiotics?
Why don't we...
Yeah, DC
What
antibiotics,
happens?
no procedures.
Well, obviously.
Yeah.
Wow. What, how'd that come about?
I think that it's just, I think he's just been kind of gradually bringing her around to the realization that he's not getting better. And I think it's one of those things where, you know, he's been telling her that and she hasn't been hearing it, and finally she started to hear it. Yeah, she started to hear it. And so we're just gonna, you know, stop antibiotics and stop lab work.
Good, no labs.
I think no
are we
labs,
gonna,
yeah. I think no blood gases and no labs.
Vent setting changes, no.
Yeah.
Wow.
It's appropriate in my mind.
Oh, yeah. It's just tragic.
Yeah, it really is. Okay, Mr. Cabra, I'll start by telling you his status, because that was the most significant event of yesterday. That is that after a long talk yesterday between Dr. Schulman and Mrs. Cabra, it was decided to actually withdraw antibiotics from Mr. Cabra and to not use pressors, to eliminate any blood drawing, and actually just maintain him on a ventilator and continue to give him his TPN, to give him nutrition. But that was about it. So that's his new disposition. Basically comfort measures only. He's on morphine as required.
I think Larry made the right decision. I mean, I think that it's been hopeless for a long time, and nothing we could really do here. Tragedy, but unfortunately that's the way it goes.
If she is competent to make a decision, then her decision has to be respected, whatever her private physician or her husband or what anyone else wants to do. Those wishes become essentially irrelevant, both legally and ethically. I mean, it's hospital policy. There's no question about it. Her wishes get respected if there's an agreement that she can understand her situation and make a decision. Now, there may be disagreement about that. I don't know, but
There wasn't this morning, but I guess if you ever look back at the past notes and you read under, her neurological status, that not everybody always agrees that she has been alert or awake.
But the question is,
to even ask
now when she makes the decision, she's now made a decision or expressed a decision, and if everybody agrees that she was with it to make it, sufficiently.
Then there's no dilemma.
Yeah, there's no dilemma.
All right. All right, well, then let's think of another one, because we got to come up with something, right?
There should be no dilemma.
Have people ever sat down in the room with her and with her husband and with the attending together and discussed this? Because that sounds like the problem.
That's today's issue.
That's the next.
That's what I've been dealing with today.
That sounds like that's no matter what you're going to decide if you haven't gotten all the people together. But this is a very different kind of tone of a discussion than the Ethics Advisory Board is sort of set up for, which isn't supposed to be complaining about whether one person or another has handled this right.
This is political rather than ethical.
I see what you mean.
To me, anyway. And ethical would be, some more question as to whether or not we really can do this. And I don't think that
There's no
at this
question
point in time in our hospital and with our counsel from the hospital lawyer and all, there's no question we can do it. We not only can do it, we have to do it.
Right, right. All right, well, then we got to think of another one.
What about the woman with breast cancer that we were talking about?
Do you remember her, Kim? She was a woman that had the tumor growing on the outside.
Yeah.
And I used to put that bark liquid stuff, some herbal, I don't know what it was, but anyway.
Tibetan medicine.
Yeah, and she didn't want to be extubated. Meanwhile, there was nothing.
Oh, yes.
Do you remember her?
Yes.
She was in room
She was
6.
in the primary, yeah.
You know, a young woman had never gone to a physician until her tumor was growing.
She
outward.
refused chemo.
And she refused chemo. And then she was on the vent and was probably ready to start to do something with the vent, and she didn't want anything different and to be supported.
And her family.
She didn't want to be extubated.
Right, she wanted to stay as she was.
Right. That to me that's an ethical issue. That actually with maybe that other woman, do you remember?
Well, that woman a couple of months ago, the one who said she wanted to live as long as she could, but the minute she went into pulmonary edema and needed to be intubated, would scream, "Leave me alone, leave me alone." She had a mental status score of 13 out of like 130. And the family wanted to make her a DNR, but every time, we would go in to talk to her.
Well, yeah, that's kind of getting more. I mean, this to me is still a sticky point for me. As to, there was another woman down in bed 11 back in July who had disseminated endometrial cancer, something that it wasn't traditional endometrial cancer, but it was some sarcomatous cancer that was totally untreatable, and everybody decided that it was untreatable. And she was going to be sent to a chronic care hospital from 5 South, and then arrested unexpectedly, and came up here and was intubated briefly, got extubated fairly quickly, and then there was a big discussion about what should be done, and she said, I don't want to die, basically. And when people went in and asked her if she wanted to be resuscitated, she said, I don't want to die. But in fact, she had a bowel obstruction, and nobody was proposing to operate on the bowel obstruction. And the issue was, what can you do in that situation, or what are you obligated to do? And it kind of strikes at the same question as the woman with breast cancer, which is, in this situation when we kind of decide that someone is terminal, in a sense, even if they wish to keep on going, how much further do you go? And the question is, what is terminal? If someone can live for 2 months on a ventilator, even with no therapy, no chemotherapy, are they terminal? I mean, the woman with the endometrial cancer, when I went in and said, you're dying, basically, she was aware of that, and really what she wanted was to be kept comfortable. We essentially told her that there was nothing more that we could do for her, and therefore resuscitation was irrelevant. How can you resuscitate somebody if there is no other therapy? And this is actually a more kind of knotty ethical dilemma to me. As to, everybody talks about care of the terminally ill, but there's no blood test for terminality. What is terminal? And you read all these things, it's kind of like competence, Everybody says determine competence, and there's no litmus test for competence.
And all these articles talk about medical care decisions for the hopelessly ill or the terminally ill, and they never define what it is.
Right.
And so you don't know whether.
What is hopeless or terminal? Because in a sense, if you decide that it's hopeless, the issue is moot. I mean, resuscitation becomes an irrelevant concept almost. But at what point, given the fact that with a lot of these diseases, we're talking about a 1 in 100 chance of surviving anyway, what is hopeless? So
what if the title for the session next week is something along the lines of, when is a terminal illness really terminal? Or when is it, something, when is it, some question along those lines, and then we can maybe even have both of them. When does a terminal illness really become terminal?
Andy did. I said, how is he? And Andy said, well, he says things like, you know, she never should have had the chemo. She never should have had the portacat. She, you know, if she hadn't had any of that, nothing. This wouldn't be happening.
Well, you know,
Okay, so
it's 5 good months better than
I don't know.
that would be fine.
8 months of hell. That's what it boils down to.
Okay, we just
A lot
wanted
of the
to touch
time.
base. What we're planning to do right now is a submax ETT foul and an echo.
I mean, you can't blame him for being. I mean, it's a lot healthier to be angry at the doctors.
Oh, yes.
And then see, we'll do the echo whenever we can get it with the
I mean, who else can you be angry at?
Okay.
Can't blame it on the
There
kids.
isn't anybody tangible to be angry at other than the doctor.
Thank you. Bye-bye.
Better us than her.
Well, I'm sure he's plenty angry at her.
Judy, what's up here in terms of blood? Well, I hope that this is fast, one way or the other. But I have a feeling it won't be fast.
God decides. God decides. We don't decide. These things have a life of their own. They really do, you know. I mean, they really do. They have a life of their own.
For Monday or Tuesday next week. Okay, thanks a lot. Bye.
She could go for 2-3 days like
I
this
always
easy.
ask that question, you know, if we had done it early, if we had caught it earlier.
Because it's guilt, you know. That's guilt. That's saying, you know, it's my fault. You know, if I had done this, if I had been a good patient, if I had known what to do, you know, would it have made any difference? The answer is always the same, even if it's true that they should have come in earlier. The answer that you give the patient is always the same. No, you did everything you could. They already. I mean, the families already feel so bad that what's the point of making it feel worse?
Hope the Swan goes all right. I mean, that was a scary thing when he said, do you know her history? She has complications with everything.
Well, it may not go all right. But you see, that's why. I mean, I think no.
Right. I think you spelled it out exactly right.
I think knowing that is helpful, though, in terms of the way you view the, you know, in terms of the way you view the procedure. I mean, knowing that, you know, that influences the way you, you know, you get a little bit less enthusiastic for it.
Well, you can't go cavalierly putting them in. But if anybody needs one, she needs one. That's what I think. Because
Right, well,
I think
you know,
we are
I
going to
guess-
be
I guess-
managing her for a while, and
Well, right,
its
but I
numbers
guess
might be helpful.
I guess the question is, you know, are we managing a chance to live, or are we managing her death? If we're managing her death, I'm not sure we need it. If we're managing her, you know, with a chance to live, then maybe we need it. See, but
I'm managing her chance to live.
right, but I'm not sure he is.
That may be. I think he's
on
trying.
the fence about that.
He's trying very hard. Well, I think he's trying. I think he's on one side. I think he's trying very hard to prepare himself for it. I mean, Andy said he was already talking about how am I going to raise the kids? What am I going to do with them? What is this going to mean to me? Do I have to quit my job? He was already, you know, Andy said 10 pages ahead of the book. So you may be right. But
That's it?
I don't know, boy. I'll know one thing. I'm glad I only do this 1 month a year.
I don't know how nurses stay here
I
all
don't
the
do
time.
that. Yeah, they do
This
it.
is actually sort of a curbside thing. It's not. It's informational.
I think it's
2 or 3
the
of these
pregnancy
and-
part that makes it the horrifying thing. I mean, age is awful, and you know, healthy is awful, and then to do this while you're pregnant.
Well, certainly the circumstances of it are, you know, far worse than incredible kind of nightmare scenarios that get played out.
Sam's, you gonna make it?
Unlikely.
Unlikely. It's a white coat day reservation for
Okay.
see you wearing your white coat.
That's a white coat. White sweater, white coat.
By the way, Mr. Cabra died yesterday about 5 p.m.
Is his wife here?
Yes, there's a post.
Was his wife here?
Yes, she was here. And actually, with her, the feeling of the family was that this was going much too long, and it was really hard for them. And they talked to Dr. Schulman about turning his FiO2 down. So we turned it down to 40%, and he flatlined a little while after that.
Probably wasn't related to that, but who knows?
So there was a lot, there's like 10 family members here. So, and she was really nice.
They don't get any pepper than that one.
Yeah. She said, if there's anything that can be learned out of this, then that's what he would want, and that's what I want. So she's she's really cooperative. So, anyways.
Okay.
I'll break it. Easier. Here, I can get it. Move your hands. I got it. Come here. Is it slow enough, guys? You happy?
Yeah.
Want to go to lunch first? Yeah. Okay. 1, 2, 3. 1, 2.
Who would like to come down with me?
Yeah. No, it's not all right. Do you have a thing for the outside? This is it. For the outside of the door? The head of the legs, not just the legs. Okay. He's really heavy. Do we need a fourth person? Do we have a fourth person to help us? Yeah. Or a fifth? Yeah.
This one we could help. This one?
Yeah.
Yeah, you want to go in there. No. You want to move him in there.
I know.
Out there. We'll be okay. 1, 2, 3. Thank you very much.
Yeah. Somebody's in there. What do we do with this stuff? I think just leave. Oh, okay.
Okay, we're going to get everything out of here.
Yeah. We're going to try.
He's a 33-year-old white male who presented in December with orchitis and had a course of antibiotics, and subsequent to that course of antibiotics was found to have a testicular mass. He underwent a biopsy which showed embryonal cell CA, and he had a retroperitoneal lymph node dissection which showed 5 out of 7 nodes positive for embryonal CA.
He had a biopsy or an orchiectomy?
He had orchiectomy with biopsy showing the embryonal CA.
Biopsy is contraindicated.
And, yeah, right. He had the orchiectomy and it was documented then, and then he had the retroperitoneal lymph dissection at the same time. 5 out of 7 nodes positive, and he received 4 courses of chemotherapy, including bleomycin. Was considered to have an excellent response. However, a month later, presented with shortness of breath, had a lung biopsy which showed pulmonary fibrosis, and his course from there was of deteriorating lung function. He presented to another hospital about, let's see, it must have been September. He presented at another hospital with acute shortness of breath, had a respiratory arrest, was found to have tension pneumothorax. Chest tube was placed. He was transferred to this hospital, the intensive care unit, where he remained for a month, and his course there was of slow degeneration of pulmonary function. He remained on a respirator, required very high settings, loss of sedation. His peak pressures were often in the 70s. He had lots of barotrauma. Besides the one pneumothorax, he had a pneumoperitoneum. He had some infectious complications with very resistant gram-negative organisms, and he required high oxygen FiO2s in the 50 to 70% range for most of the time he was in the unit. His family and his wife specifically followed his course over all this time, and eventually she made the decision to not have CPR performed if that was the case. And following that decision, about a week later, she came to the decision to decrease his FiO2, and he expired shortly after that.
So the questions for the autopsy were, going back to the original process, what is the extent of tumor at autopsy? Of course, 10 or 20 years ago, he would have died of metastatic embryonal carcinoma. Another question is to document the nature of the pulmonary process to determine if, in fact, it was an irreversible process likely related to the bleomycin treatment and subsequent treatment. And finally, to look for unexpected processes that might have helped to explain some of his kind of clinical course. Go ahead.
So the autopsy was a large gentleman, and on careful dissection of the retroperitoneum, we revealed multiple adhesions, but no gross evidence of tumor in lymph nodes. He also had a history, apparently, of a congenital absence of a left testy or atrophy, and there's no evidence of that. He had had a right orchiectomy, so the right testy was also gone.
Basically, there was no evidence in the gross of any residual tumor.
No microscopic surpending. The most remarkable evidence was found in the thoracic cavity. He had 100 cc's of serous sanguineous pleural effusions bilaterally, and both of his lungs weighed approximately 800 grams, which is
You really should feel these.
put on gloves. 3 times normal.
I think the important
Virtually no airspace is in here.
Yeah, looking at them, it isn't evident how fibrotic they are, but to touch, it's a very woody consistency.
I think, too, that there was extensive fibrosis, and there seems to be a superimposed
There's a band of fibrosis right there.
I think all
abscesses, small focuses abscesses, and post-mortem cultures were positive for gram-negatives and staph epidermis.
Some emphysema change.
Subpleural
on the other side.
A little. I think that fits in with the fibrosis.
Fibrous adhesion.
Of course, at this stage, any of the number of things can present a picture like this, but it is completely consistent with bleomycin-induced fibrosis, perhaps with a component of ARDS as well, diffuse alveolar damage. I think when the clinicians come, we'll take the opportunity to mention how posts were important in characterizing this form of toxicity. So there really were no surprises at autopsy.
No.
This is an example of curing the tumor, but the cure is deadly. And the therapeutic index is very low.
Unfortunately, we only see these patients at this point, but I think it's significant to mention that only a real small percentage of the patients have toxicity to bleomycin, and this kind of a cancer has a 80 to 90% cure rate, and fortunately there's 1% or small percentage of patients that get drug toxicity.
Okay, why don't we do the next?
Sure.
Thanks.